Thank you, Mr. Chairman, and I thank the witnesses for testifying before the subcommittee today. It's no secret that PBM middlemen artificially inflate the cost of and limit access to prescription drugs. This occurs at the expense of patients who receive health insurance in public and private markets and impacts patients of all ages. The PBM market has become highly consolidated, with the three largest PBMs controlling roughly 80% of prescriptions. The top 6 PBMs account for about 97%, and in Medicare Part D, 4 PBMs manage benefits for a combined 90% of beneficiaries. PBMs claim they reduce prices by holding pharmaceutical companies accountable. This is done, they contend, by requiring rebates on drugs, which are then passed on to the beneficiary. While PBMs often do negotiate discounts for manufacturers, patients are not the ones who benefit from them. In Medicare Part D, for example, patient cost sharing is based off the list price of drugs, which are artificially inflated to extract a higher rebate. As a result of these practices, for 79 of the 100 most rebated drugs in Medicare Part D, beneficiaries pay more for their drug than their insurer, again demonstrating that beneficiaries, in this case seniors, are not benefiting from the rebates. This is why I led the bipartisan Share the Savings with Seniors Act, which would require full rebate pass-through for chronic care drugs under the Medicare Part D plans. And that's not the first time I tried to do PBM reform. My first effort at PBM reform came as a state senator in 2019, where I passed PBM reform on transparency, but could not get a pass-through of 51% of the rebates. The insurance companies were against me, my manufacturers were against me, as it was alluded to them that drug prices would rise and people would use brand name drugs rather than generics. So I've been at this now for 6 years. And when I was in Iowa last week, I read, despite all of the hurdles I had, PBM saves county money. The county adjacent to my district saves $60,000 of their county expenses with PBM reform, and now states are doing it. This isn't a partisan issue. We have over 200 pharmacies have closed in Iowa since 2014, which includes not only independent locations, but chain pharmacies such as our Hy-Vee pharmacy, and we know the bigger pharmacy chains are also closing. I'm very proud of the bipartisan work this committee has done to move on meaningful PBM reform legislation through regular order. Last Congress, the Energy and Commerce Committee successfully moved 3 major PBM policies: Medicare Part D delinking, commercial market transparency, and banning spread pricing in Medicaid. And I've done the same thing in the commercial market with the Drug Act. Mr. Grimminger, we hear from insurers and PBMs that implementing delinking won't have any meaningful action on reducing patients' out-of-pocket cost in the commercial market. However, we know that commercially insured patients are largely more exposed to list prices through larger deductibles than patients in Medicare Part D. In fact, in 2024, the average annual individual deductible for employer-sponsored health insurance was $1,787, while the maximum annual individual deductible in Part D could not exceed $545. Do you believe that if we move to regulate delinking in the commercial market, such as my bill, the Drug Act, would do, would that reduce patient out-of-pocket cost?
In short, yes. The National Alliance supports actually applying delinking to the commercial market. As you know, right now, the bill that was considered in December only applies it in the Medicare market. There's no question it takes away a financial incentive that's currently built into the program, and I absolutely believe that doing it in the commercial market will ultimately lead, in relatively straight order, to lower out-of-pocket costs for consumers.
Mr. Clancy, I'm going to ask you a question, but I want to dedicate this question to John and Jane Nicholson, who run the Mahaska Drug Family Pharmacy in Oskaloosa, Iowa, which is teetering on closing. It's my understanding that Caremark, one of the 3 big PBMs that controls 80% of all prescriptions in the country, has a request for proposal out to pharmacies asking them to do 2 things. And sometimes this information and contracts are sent by fax, which most people don't utilize. So in order to be considered part of the network of covered pharmacies in their Medicare prescription drug plans, 1, offer an amount of reimbursement that is below what it costs a pharmacy to acquire and dispense medicines. Force pharmacies to select which of their competitors Caremark should remove from the network, a blatant disregard of Medicare Part D's any willing provider requirements for pharmacy, which state that any pharmacy that agrees to a Part D plan's standard contract terms and conditions must be allowed to participate in the plan's network. Is it not the exact type of anti-competitive behavior everyone has been pointing to for years now? And does it demonstrate why we need stronger protections for all pharmacies serving seniors in Medicare, not just those owned by PBMs?
I very much agree. And in Georgia, Caremark covers our state health benefit plan. And I ran my reports before I came, and 24% of the prescriptions I dispense, I get reimbursed below my cost of purchasing the drug. 75% of the prescriptions that I fill are below my cost of doing business. So 25% is actually my gross profit scripts.
Thank you so much. I yield back.